Yeah, okay, you can start. Thanks.
Okay, so good afternoon, everyone. I'm Lillian here. I'm going to actually share some of my reading on applied anatomy and physiology of one of our very vital organ, which is our lung. It's quite a long topic and physiology part. So I hope you bear with me. First of all, we just do some breathing exercise to calm down and breathe out, and let's start. I'm going to talk a little bit on embryology, some of the anatomy, the lung physiology, and the gas exchanges, and what's the difference between children and adults. As we know, the lung doesn't perform any respiratory function during the intrauterine life. So they're actually responsible to produce amniotic fluid. And the lung development is classically divided into 5 stages, where they undergo 23 levels of ramification from the trachea. So from the foregut itself, it goes forward and backward to form endodome and ectoderm, where the ectoderm form the trachea, the endoderm form the esophageal tube. So there are 5 stages. During the embryonic phase, from week 0 to week 7, the trachea will be formed and is subdivided into right and left main bronchus. In the second phase, whereby pseudogandular stages, terminal bronchus are formed and all the pulmonary vessels started to gather. At the canacular stages, which is 17 weeks up to 27 weeks, the respiratory bronchus, the alveoli, important moment is around 23-24 weeks. The first surfactant will be detectable in our alveoli. The alveoli become more and more. There's multiplication of alveoli, and to make the baby viable. And our lung development doesn't stop there. It actually progresses from birth until around 8 years old, whereby our alveoli doesn't actually increase in number, but they increase in sizes. This is a bit of repetition of what I have told you just now. So from trachea down to our bronchus, the conduction area, like what I have told you, they undergone 23 times of branching. The first dichotomy happened where your trachea formed the carina and is divided into right and left main bronchus. So on the right side, the second dichotomous happened where it they actually subdivided into right upper, right middle, and left middle lobe, whereby we have 3 lobes in the right side of the lung. On the left side, on the other hand, the second dichotomous only separate and give rise to left upper and left lower bronchus. There's no middle lobe bronchus of the left, but rather there is actually a rudimentary bronchus called the lingula. So these 5 lobar bronchi actually further divided into 18 bronchopulmonary segments. For our respiratory division, there's upper airway and lower airway. The upper airway include from nose until our larynx, which they actually play a role in terms of swallowing, smelling, and also talking. The lower airway start at the junction between the larynx and the level of the vocal cord, and it go downward until our alveoli. So this lower airway is further divided into 2 components. The first is the conducting zone, which is from the proximal, which is actually proximal to the terminal bronchus. And so from trachea, from the vocal cord, trachea, the main bronchus, and until the terminal bronchus, they actually form an anatomical dead space, which this area doesn't involve in any gaseous exchange. The second part would be the lower part, other distal to the respiratory bronchus down to the alveoli, is called respiratory zone. And this is a zone whereby there is oxygen and carbon dioxide gas exchange happen. So for respiration itself, it consists of 4 distinct processes. First is about breathing. The pulmonary ventilation is how our air move in and move out from the lungs. External respiration consists of diffusion of gases between the alveoli to the pulmonary capillaries. And then we transport oxygen and carbon dioxide. And internal respiration is actually talking about diffusion of gas between the the pulmonary circulation to the tissues. So first of all, the pulmonary ventilation is actually the physical movement of our air in and out of our body. And this mechanical process it depends on volume changes in our thoracic cavity. So volume changes lead to pressure changes and vice versa. Gas move from a higher pressure to a level of lower pressure. From Boyle's law actually tell us about pressure and also volume. Boyle's law tell us that when we are at a condition of higher volume, our pressure will be lower. When we are at a condition of higher pressure, the volume is supposed to be lower. So look at the two cylinders there. They are actually having the same amount of molecules. Each cylinder have 8 molecules. But when you actually exert pressure towards the right-sided of cylinder, you notice when you are at a higher pressure condition, the volume becomes smaller. So this is actually applied to the state of how we breathe in and breathe out. Because, Boyle's law states that relationship between pressure and volume of gases is inversely proportional for the gas held at a constant temperature. So look at the right side of the picture. As our diaphragm contracts, it actually increases our intrathoracic volume. So Boyle's law stated when our volume increases, the pressure drops. So when the pressure drops, the air will come in. That's why the balloon will actually puff up. So this is the mechanism of how we inspire. So vice versa, when your diaphragm relaxes, the thoracic volume actually reduces. So when the thoracic volume reduces, pressure actually increase, and this external pressure will actually cause air to go out from our lung. This is the process of expiration. So the mechanism of breathing mainly due to contraction of diaphragm and intercostal muscles, which actually innervated by our phrenic nerve. So thoracic muscle pull the chest wall outward and the volume of thoracic cavity increases. I would like to introduce some pressure relationship in the thoracic cavity. So when we are breathing at the atmospheric pressure, the pressure exerted by all the gases in the air that we breathe in is at the level of 760 millimeter mercury at sea level. So our intrapulmonary pressure is the pressure within the alveoli, and it actually equalizes itself with our atmospheric pressure. But so when we actually equalize with atmospheric pressure, they were actually in a constant state. But what make the lung expand? So this is actually due to an intrapleural pressure. The intrapleural pressure is normally lower than the intrapulmonary pressure, whereby it's actually less than 4, 756 millimeter mercury if compared to the atmospheric pressure. So this form a transmural pressure gradient whereby our lung can expand. Second law that I would like to introduce to you is the law of Laplace, because this is actually a very interesting law that tells us how our alveoli works. Law of difference between these two inversely proportional to the radius. Can you hear me? Because my line is actually breaking. Dr. Cho, can you all still hear me?
Can. Yes.
Can.
Okay.
So let's look at the alveoli A and alveoli B. So what Laplace law tells us that pressure is equivalent to 2 times of surface tension and inversely proportionate to radius. So imagine alveoli A is at the 1 centimeter, alveoli B is at the radius of 2 centimeter, where they have the same similar surface tension. So the pressure in the alveoli A is supposedly higher than the pressure in the alveoli B. So what I have told you just now, the airflow will be flowing from the higher pressure to the lower pressure. So supposedly, when you actually connected these two alveoli through a tubing, you will see the alveoli A is supposed to actually empty into the alveoli B. So does it happen in this way in our lung, that whenever higher pressure in the alveoli, they will actually collapse into the second alveoli? No, right? So Laplace law telling us that this should happen, whereby the lung would collapse into the other alveoli because of a difference in the pressure. But luckily, there's one magic thing that we have, which is a surfactant. So look at the first picture. When there is no surfactant lining, the surface tension is actually equal in between alveoli 1 and alveoli 2. So when they have equal surface tension, the alveoli
Feeling we lost you. Hi, Lily. Lily.
Dr. Chua, I'll go and see what's happening.
Yeah. Relax.
it's not so good. Maybe. But I'm using my phone right.
Okay, we got things under control. She will be online within a few seconds.
Hi, Chi. Insan, are you there?
Yes, Dr. Chua, I'm here.
Oh, okay. Michelle with you.
Michelle. Father.
Both of you in IGN.
Yes, yes. Both of
Oh,
us in IDN.
I get them time.
Huh?
I get them time.
Oh, good. Thank you very much. Yeah. Your boss is here.
Hmm. Hey, do you all have the list of topics that will be presented?
Yes, yes. I'll
Yes.
share in the group later. Yeah.
All right.
Okay. Yeah, Nisan, so as you know that there will be new generation in the lung. Yeah. So that we what we call a generation. Yeah. So the branching, each branching is that's one generation. You know, at which generation they will be starting to form alveoli.
Tak apa macam ni. Airdrop. Boleh airdrop? Tak. Ooi Li accept.
So yeah, not
Isan.
Yes, Dr. Cho.
Yes, yes. So you know that just how we discussed, there's a few generations of the 23 generations of the lung development. Yeah. So you know at which generation they start to have developed alveoli?
Which generation? At which phase of the lung development is it? Or
At which generation? Yeah. So they're all together 23. Yeah. At which generation they will start to form alveoli?
don't know.
Anyone know? So you know that the embryology development. So
the
I mean,
canicular to the secular phase,
Secular.
but generation, yeah.
yeah.
I mean the lung, the phase of the lung, the 5 phase of development should be the canalicular to the secular phase, and there's a point where we have our alveolar development. But
At which generation?
tak tahu.
Anyone know?
I think just now she mentioned 23 is conducting, then after beyond that another 18. So I assume it's 23 plus 18.
So 17 and onwards. Yeah. So so the embryologically the trachea, we start with the trachea buds. With the small little trachea buds. So when we say generation, that means that so from the trachea bud, then it branch up to 2. So that is so from 1 generation to 2 generations. So there are 2 generations already. Then further divide, then be a 3rd generation. So initial 16 generation, they usually we call it conducting system. And then when you start from the 17 and onwards, then they will be starting to form alveoli. So that's where the alveoli start to form. Yeah. So when the alveoli start to form, then that's the time that only oxygenation can occur. So that's why when you're looking at the gestational age, so when a baby are too premature, when they are born at 20 weeks or 22 weeks, all these alveoli are not actually formed very well. Yeah. So or maybe can be absent properly. So with that, you can't actually survive. So this is very important. So looking at how many weeks whereby the alveoli develop. Yeah. So and also at which generation are the alveoli start to develop. So they mean starting from 17 onward, 17, 18, 19, 20, 21, 22, 23. So they are the branching subsequently with associated with the alveoli. Okay, back to you, Lily. Yeah. Yes, you muted as well.
Yeah, Lilin is using my computer.
Okay, okay. Unmute, yeah. Boleh dah.
Can you? Tak dengar.
Dengar. Yeah.
Dengar?
Yep, dengar.
Okay. Oh ya ke? Okay. Boleh?
Macam ni tengok. Okay. So I start.
Yes.
Okay, sorry everyone for the interruption.
You need to speak louder, Lily.
Your volume.
Okay.
I start balik ah. No, I start balik ah.
Boleh. Okay.
So just now I was talking about the Laplace law lah, where it actually tells us that pressure go from higher to lower, and the pressure actually inversely proportional to our radius if our surface tension is at the same surface tension. So, but this doesn't happen in the normal lung because we have surfactant. So when we have surfactant, the surfactant will actually lower the surface tension, especially in the smaller molecules or smaller alveoli, because actually the surfactant is closer to each other. So the effect is maximized by lowering the surface tension. So when you're having the look at the second picture, the alveoli one having a lower tension or a lower radius, making this is all my reading. Okay. Yeah. Again. Sekejap Aku macam mana nak off the yalah, your connection tak stable.
Try ni sekali lagi.
We can hear you. We
Tak
can
boleh
hear you.
dengar.
We can hear you. Lily.
The connection.
Yeah, our connection here is actually quite poor. Okay, so this is about Laplace law. Why our alveoli doesn't collapse from smaller alveoli to the bigger alveoli is because of the presence of surfactant. Next, talking about the lung volume and lung capacity. Basically, lung volume and capacity refers to the volume of air that actually associated with different phases of our respiratory cycle. Tidal, in this graph, the smallest volume, which is the tidal volume, is the amount of air that in and out from our body after a typical inspiration. Expiratory reserve volume happen where there is additional volume that we forcefully expired. Inspiratory reserve volume is the volume, additional volume that we actually take a deep breath. Residual volume is the amount of air that stays trapped in our alveoli. When there is 2 or 3 volume that we sum up, we will have capacity. So vital capacity is the sum of the volume that we have during our normal inspiration and expiration, plus the volume that we forcefully inhale and also expired. Inspiratory capacity is the tidal volume plus inspiratory reserve volume. Functional residual capacity is the expiratory reserve volume plus our residual volume. And the total lung capacity. We have 2 dead space. One is anatomical dead space, whereby this is the dead space happen in our conducting system, in the trachea, in the carina, until the terminal bronchus, where they are actually not in charge of any gas exchange. Alveoli dead space is the dead space in the alveoli that actually this alveoli is not acting in their normal way. They are either collapsed or they got a lot of obstruction. That's why they are not able to perform any gas exchange. The total lung volume curve, the total lung volume understanding is very important for us to actually practice during our normal practice, is because it actually tells us more on how we differentiate the spirometry results. So as normal lung, we should have a normal value of first, second, forced expiratory volume, which is more than 80% of the normal predictive value, and the forced vital capacity also should be more than 80% of our predictive and of the normal value. When you have an obstructive pattern of a lung, for example, in the asthma child, they will actually have a lower FEV1. Look at the blue line. You see the first forced expiratory volume in obstructive lung disease child, they are significantly lower at the FEV1. However, these children, they are still able to actually forcefully exhale. They are taking longer time, but the total volume that they exhale at the end of the day is still will be near normal or slightly lower than a normal children. So when you compare the FEV1 ratio to the FVC, there is a disproportionately reduction of FEV1 in relationship to the FVC. On the other hand, if you are having a child with restrictive lung disease such as cystic fibrosis, both the FEV1 and at the end of the day, the FVC also will be significantly reduced. So when you compare the ratio, they are actually near normal or normal. Next, I will talk about external respiration. This is a gas exchange between the alveoli and our pulmonary capillaries. So factors that influence the movement include our respiratory membrane structure, our partial gradients of our pressure and the gas solubility, and our matching of alveoli ventilation and pulmonary blood perfusion. So this is our respiratory membrane, whereby this is the fusion of the alveoli and capillary wall. They actually fuse together and form this air-blood barrier that allows gas to go in and go out from each part. So gas exchange occur readily by just a simple diffusion based on the pressure gradients. The red color one is a type 1 alveoli cells. Is actually a primary precursor of our angiotensin converting enzyme, whereby the type 2 green color cells is a very important cells that actually produce surfactant. So there's another law, which is Dalton law, tells us that the total pressure exerted by a mixture of gas in the sum of gas exerted independently by each gas in the mixture. So when the mixture of gas in contact to the liquid, the gas will dissolve in the liquid in proportionate to the initial partial pressure. So in short, the amount of gas that dissolves in the liquid is actually depends on its solubility. So different gas have different solubility. Carbon dioxide is most soluble. Oxygen is only 1/20 as soluble as carbon dioxide, whereby nitrogen is definitely not soluble at all. So this is what happened in our external respiration, whereby the partial pressure of oxygen in our venous blood is around 40 millimeter mercury, but the partial pressure of oxygen in the alveoli is around 100. So when there is a partial pressure gradients happen, the steep gradient allow the oxygen to flow from the alveoli towards the pulmonary vessel. This also happens as in carbon dioxide diffusion. Although the carbon dioxide doesn't have a very steep pressure gradient, but bear in mind, carbon dioxide is 20 times more soluble in plasma than oxygen. So the flow is not being affected. Next, I will talk about internal respiration. Internal respiration happens between the systemic capillaries and the tissue cells, and it's almost the same action as in happen in the lung, but it's actually a total reverse action whereby oxygen go into the tissue and carbon dioxide go out from the tissue. For the optimal gas exchange, it involves a very close match of this ventilation and perfusion coupling, whereby both are controlled by a local auto-regulatory mechanism. So PaO2, they controls the perfusion by changing the arteriolar diameter. PCO2 control the ventilation by changing the bronchial diameter. But however, we have so many alveoli, it never balances in all the alveoli because different alveoli have different sizes, and some of the alveoli are clogged with mucus, and also it's also always based on the gravity on the blood and the airflow. For instance, when our alveoli have high oxygen, the arterioles will actually dilate, whereby where the oxygen is low, the arterioles will constrict. So when the oxygen is high in our alveoli, the arterioles dilate so that more oxygen can go from the alveoli into the blood vessels. Vice versa, when the alveolar carbon dioxide is high, the bronchus will try to dilate so that it allows more carbon dioxide to go out from our lung. So the changing of diameter of the bronchus and the arteriole synchronizes alveolar ventilation and pulmonary perfusion. For example, when you have low oxygen and high carbon dioxide in the alveolar, pulmonary arteries will actually constrict and the airway will dilate so that it bring in more airflow. But in another condition where you have a very high oxygen and very low carbon dioxide in the alveoli, the bronchioles will actually constrict. So it promotes more air, more blood to flush into more oxygen to flush into our pulmonary capillaries. Next, I will touch a little bit on oxygen dissociation curve. We have two types of hemoglobin. One is deoxygenated hemoglobin, and another form is oxygenated hemoglobin. In the deoxygenated hemoglobin, their units are actually tightly formed, whereby they are in a tense configuration. So these deoxyhemoglobin, they are actually very reduced. They have a very reduced affinity of hemoglobin molecules to oxygen. However, when there is one single oxygen being bound to this tightly bound globin chain, it actually releases this deoxygenated hemoglobin configuration from tense to a relaxed condition, which means that when you have first oxygen being bound, the second, third, and the fourth oxygen is easily bound to the hemoglobin. So look at this oxygen hemoglobin dissociation curve. When you have a normal curve and a sigmoid curve, there is certain condition that actually causing a right shifted of the curve. For instance, you have a high carbon dioxide, low pH, higher temperature, and also lower affinity of the HB variance. It's actually very helpful in terms of they actually help to reduce the oxygen affinity and increase oxygen delivery to the tissue. So on the other hand, the left shifted oxygen hemoglobin dissociation curve happen, whereby you have a high pH due to a low carbon dioxide, or you actually have a different hemoglobin condition such as methemoglobinemia and carboxyhemoglobinemia. So this oxygen hemoglobin dissociation curve actually a very useful principle that applied on our pulse oximeter. So our pulse oximeter utilizes the electronic processor, whereby it actually measure two different wavelengths of our light, which is a red light and also infrared light. So this different hemoglobin loaded oxygen will actually absorb the light differently. Oxygenated hemoglobin absorb more infrared. Deoxygenated hemoglobin absorb more red light. So the microprocessor will calculate the ratio and actually display as a SpO2 reading. So when we are anemic, currently we are actually rely very much on our SpO2 to judge the PaO2 available in the body. So to judge the oxygen condition in our body. But bear in mind, there are certain conditions that SpO2 is not so reliable. For instance, when you are anemic, your HB is low, you may still have a normal SpO2, but in fact, there is actually very low oxygen content in the blood. Second condition where you have abnormal hemoglobin molecules, such as a sickle cell anemia. Because sickle cell anemia causing a right shifted oxygen dissociating curve. So the SpO2 may be low in that condition, but in fact, this patient is actually having a higher partial pressure of oxygen in their body. So it may lead to overdiagnosis and overtreatment. Of course, a nail polish, skin pigmentation also skew the pulse oximeter results. Long time ago, people talk about black color, the dark color like black, dark blue, and also green color. They actually causes skew in terms of the pulmonary, the pulse oximeter will drop almost 5% than the normal. So supposedly the child is actually normal SpO2, but the SpO2 display on the monitor is actually 5% lower. But a newer pulse oximeter actually improve a lot. Even a very dark color nail polish, or actually the brownish, the one that people use, the E9, they will actually only drop the saturation and the SpO2 around 2 to 3%. Fourth condition is in the patient with carboxyhemoglobin or methhemoglobin. So these two conditions actually shifted our oxygen distribution curve towards the left side. So therefore, our pulse oximeter may falsely reported very high saturation, but in fact, the tissue are not receiving any or not receiving sufficient oxygen. So look at the wavelength of the different hemoglobin and their different absorption coefficient. Interestingly, the carboxy hemoglobin and our oxygenated hemoglobin actually have the similar absorption coefficient, and the met hemoglobin as well are actually quite identical if compared to our the oxyhemoglobin. Okay, next I will touch a little bit on the respiratory center. So our respiratory center located in two main area. One is the medulla oblongata, which actually decide on the rate of our normal breathing. And second area is the pons, which actually regulate the depth of the breathing. So in the medullary respiratory center, there are two groups of respiratory impulses happen. The dorsal respiratory group actually stimulates inhalation. Then expiration actually happen due to the elastic recoil of the lung. The ventral group actually remain inactive during the normal breathing, but it involved in forced inspiration and expiration. So all these two groups actually act through the phrenic nerve to actually stimulate our intercostal muscle and diaphragm to breathe in and breathe out. The pons respiratory center, they consist of two more sub-center which influence and also modify the activity to smooth our inspiration and expiration transition. The pneumotaxic center is act as a regulator. It will sense the overinflation of the lung, and it actually sending the inhibitory impulse to our DRG, our dorsal respiratory group, to cease the breathing. So it prevent our lung overinflation and prevent pneumothorax. Amnesic center is a very interesting center whereby it coordinate transition between the inhalation and exhalation by fine-tuning the other center. So the impulses will result in slower and deeper inhalation, especially when we are holding our breath. Our lungs are supplied by two circulation. One is pulmonary circulation, where it happens in alveoli, where it actually the deoxygenated blood come from the heart, go to the alveoli, and then the blood get oxygenated and go back to the heart. Another circulation is a bronchial or systemic circulation, where it arises from an aorta and is supplied to the lung tissue, but it doesn't supply the alveoli because the alveoli was supplied by the pulmonary circulation. Okay, so next I will talk about the main difference between the pediatric and the adult airway. Pediatric airway is more rostral. Our laryngeal apparatus develop from the brachial cleft and they descend caudally. So the infant larynx is normally higher and more anterior compared to adult. And secondly, our infant larynx are funnel in shape. So the narrowest part of the larynx is actually at the level of the underdeveloped cricoid cartilage. So when you intubated a child, when you see your EDT nicely fit in on your vocal cord, but in fact after you extubate, you hear a very loud stridor. It normally happens in a young and smaller infant. Is due to this concept because their larynx are funnel. The narrowest part is not at the vocal cord; it's actually at the cricoid. So although you see you actually have a correct size of ETT, but in fact, you will still have the problem of extubation stridor. Next, the diameter of the airway. So there's one interesting law created by one French physician, talk about this Poiseuille's law, and it shows that the airway resistance, the R, the bigger R, is inversely proportional to the radius to the power of 4. Look at the first picture. When you have an infant with normal tracheal diameter of 4 mm, when they are having edema, let's say their edema up to only have a pinhole kind of trachea, then at the cross-sectional view, it's actually significant reduction of almost 70% of our airway. Whereby in our adult, although they are actually also causing edema in adult, but because of their cross-sectional radius is actually higher than children. So in terms of their reduction of cross-sectional area in their trachea, is actually much more lower. And our infant also normally have a larger tongue. Their heart is bigger. Their occiput is more prominent. So larger tongues are normally tends to fall backward and also obstruct our airway. And infants' vocal cord are actually more angled, and whereby the adult vocal cord are more perpendicular. And infants have different shape of epiglottis. The epiglottis are longer, they are more stiff, and they are omega in shape. So it tends to flop posteriorly and obstruct the airway. Another thing happen in children is due to the horizontally set ribs. Because in adult, their ribs are actually grow lower down. So when they are actually inspire, when the lung expanded, they're actually causing one bucket handle action whereby it capacity. This doesn't happen in children because their ribs are actually horizontally attached. And so for children, their ventilation mainly rely on the diaphragmatic concept. When you have a limited or splintered diaphragm due to either ascites or you have organomegaly or you actually back too long, the diaphragm will get splintered and it actually impairs our ventilation. Last but not least is due to the compliant chest wall. Anyone less than 3 years old, there's very ineffective chest expansion, especially when they are sleeping. So during a normal respiration, you are expecting the chest and the abdomen rise with inspiration, but it doesn't happen in a younger, smaller child because their chest wall, in fact, instead of rising, they actually retracts. So you will see this kind of seesaw breathing, the chest is collapsed instead of expanding. I think this is my last slide. Yeah, thank you.
Thanks, Ling. Yeah, any question? Any question from the floor? Can I ask Lily? Yeah. Yeah, if not, then let's go to your slide. So you go to the next slide. Yeah. So you go up. Yeah. Yeah, this one. So just now we have discussed the generation. Yeah. So each branching will be one generation. Yeah. The previous slide. Yeah. The previous slide.
Previous slide also.
Yeah, this one. So it's important. So that during the start, the alveolar budding, the budding of the alveoli is somewhere at the 17 to 18 generation. Yeah. So when the budding subsequently gradually improve. Yeah. So the importance of the is to say which group of patients, especially in the terminal unit. Yeah. So the other important thing is that so when the common question that I like to ask my house officer is when you go to the next slide. The next slide, yeah, this one. So when they say there's a bronchospasm, so commonly the bronchospasm occur at which level? the patient has severe asthma, bronchospasm usually occur at which level? Yeah.
The bronchi level,
Mhm.
because they are non-cartilaginous.
Bronchi level. Yeah, yeah. So it's at the terminal bronchiole. Huh? The terminal bronchiole means that so the terminal bronchiole is quite important, meaning that they are at the lower end of the generation. Yeah. So say about 15, 16, 14, 15, 16 type of generation. Yeah. So in which they have incomplete cartilage. Yeah. So they are incomplete cartilage when you go all the way down. So the first at the trachea area, you got a complete C shape of trachea ring. So when they branch down at the carina area, branch or two, so the main bronchus itself has a complete ring of the bronchus. Yeah. So and subsequently, and then they branch out to the terminal bronchiole at the 14, 15, 16 type of generation, whereby they will really have incomplete bronchial, the cartilage ring. Yeah. So that's whereby when they lost the cartilage ring, but then they still have smooth muscle. So that's the area that they can be a bronchoconstrict. Because a lot of misnomer when you say that bronchospasm, yeah, my health officer always say that it is at the main bronchus that spasm out. Yeah. So that's also quite important in terms of the when you give MDI or nebulizer medication. Yeah. So have you ever wonder when you give nebulizer medication, so how much of flow that you're going to deliver to create the nebulization?
How much of flow?
What is the flow?
More than 6 liter. More than 6 liter.
Yeah, around 5 to 8 liter type of flow.
5 to
What's
8.
What's the reason that you want to put at the 5 to 8?
Want the flow, the speed to push the air further down to deliver the medication to the terminal bronchioles.
Oh, okay. Yeah, any other answer?
Any other answer?
Yeah. Because we see that most of the time in the ward, right, the nurses will put up within 5 to 8. Yeah. So do you see the difference in terms of the appearance of the vapor when you created at a different flow rate? Yes,
the is smaller. Everything is smaller because pressure is higher.
Yeah, correct. So the size of the vapor are quite relative to the speed of the flow, the airflow that we generated. Yeah. So it's also using the Venturi effect or your Bernoulli effect, or the Venturi effect, which is also correlate with the Venturi effect. So you will see there's the cone inside the nebulizer chamber. So the speed of the flow, the higher the speed of the flow that you dial into the system, the smaller type of molecule, the vapor that you're going to create. Yeah. So if you can, if we fix the flow rate around 5 to 8, so the vapor size will be small enough until they will deposit maximally at the terminal bronchial area. So that's very important. Yeah. So the lower the flow that you give, so let's say you give only 4 liter, right? The vapor that you're going to produce will be the size of the vapor that you're going to produce is very big. So you're going to deposit on the upper airway. So you even go there's the less likely to go down. Yeah. So that's important. Yeah. So if you give too high a flow, let's say 9, 10, so the vapor is too small. So I mean there will be especially when you see the nurses dial the flow, you're going to be like a cloud like that, flying all over the face, because the vapor are very, very small. When the vapor are very small, it tend to fly up and then disperse around, and then the maximum deposit area might not be at the terminal bronchiole. Yeah, so it is somewhere at the alveolar level. So that is an important part. Knowing that the type of the flow that you're going to deliver. Yeah. So in the pulsatile manner that the machine, the intermittent pulse, they already fixed onto the flow rate. So that's why we did not observe much the flow rate in such a way that the maximum deposition is bronchial. But then the problem is our side is that it's oxygen flow that we need to decide ourselves. Yeah. Okay. So the speed of the flow doesn't mean that to push it down. No, it's basically is to create the size of the vehicle. Yeah. Move on to the next slide. Yeah. Next slide. Okay, next slide.
Next again, is it?
Yeah, this is just with the division. Okay. Right, next slide. Yeah. Next slide. Okay, next slide. Next. Yeah. So now it's quite important. So now you got the atmospheric pressure. So your atmospheric pressure about 760, correct? Yeah. So when you say 760, so how much in this 760? How much is the contribution by the oxygen?
Oxygen is 21%, so it's proportionate, which is around 158, 56.
158, correct? Huh? So your atmospheric pressure is 760, then your oxygen partial pressure is 158, correct? Millimeter mercury. Okay, huh? Right. So how about when you inhale? So let's say you put the patient, we are inhaling now, 21%. When you inhale now, so how much is the oxygen partial pressure when you reach the alveoli?
Is it?
Sorry.
35.
35. No. So now your atmosphere have 760 millimeter mercury type of pressure. So out of this 760, the oxygen, you say that it is 21%, correct? Yeah. So this 21% out of 760 is about 15 something, as you mentioned, correct? Correct, huh? Correct. Huh? Okay, all right. So just now so what will be the oxygen partial pressure when you reach down to your alveoli? Would it be 150?
No, I don't know.
Anyone?
I guess it's not the whole total 21% that we receive.
No. You inhale air, right? You inhale air. So we are inhale 21% out of atmospheric pressure, which is about 760 millimeter mercury. So 21% out is 150. Huh? You inhale down. Huh? Okay. So what would be the alveolar level of partial pressure oxygen when you inhale?
Not sure.
For sure. Inside or person?
It will be 100 if there is no issue with the oxygen reaching the alveoli. It will be near 100.
Near 100. Why is it so? But you're inhaling 150. Why reach your alveoli become lower? Yeah. Okay, so there are two important factors that change the partial pressure when you inhale. So you have to remember when you inhale. So the thing change is that first is the temperature change, right? Second is the humidity change. Temperature, humidity, and also carbon dioxide concentration, right? So when you inhale, we're going to warm up our air, and then the humidity is higher, and also the concentration of the carbon dioxide will be higher. Yeah, so that will subsequently drop down the concentration of your oxygen. Now remember, this atmospheric pressure is very much affected by the temperature, humidity, and also the carbon dioxide. So that's why when you inhale down, so it might be reaching to the alveolar end maybe about 100 to 120. So that's why when the diffusion occur in your alveolar level, right? So when you do the ABG, your normal ABG is around 90 to 100, right? Yeah, 90 to 100 millimeter mercury. So that's why, I mean, it's a big discrepancy because atmospheric pressure is 150, but then when you inhale down, it already become maybe 110 or 100 level. And then when you diffuse through the alveolar, it comes down a little bit more, 90 to 100 because of because of problem of diffusion at time. Yeah. So it's very important clinically, yeah, because especially when you ventilate patient. So remember, a lot of time when we ventilate our patient, we're using quite a lot of humidity, yeah, especially in pediatric. So the humidity itself sometimes can reduce the total percentage of the partial pressure of the oxygen that you're going to inhale. Yeah. You get what I mean? Meaning that
meaning, sorry, Dr. Chow, Michelle, meaning
sure.
they're saying that the higher humidity, it will also reduces the pressure of, the partial pressure of oxygen that reaches to the alveoli level.
Yes, yeah, the humidity, the humidity, the temperature, and then the carbon dioxide content, because they already cloud out the place. Yeah.
Okay.
So that's why if you use a dry circuit, as compared to the humidified circuit, yeah, the dry circuit oxygen delivery, although similar FiO2, yeah, but then when you reach out the lung, the alveoli, they'll be slightly different. Yeah, whereby the dry circuit might have higher partial pressure oxygen when you reach out your line as compared to the humidified one. Yeah.
I see. Okay.
Yeah. So that is a bit of physics. The importance of a site. I mean, is you will not see much in clinical, but then this is something that you need to be understand why when you do AVG, right? You do AVG, why we will say that atmospheric is 21% oxygen, whereby your partial pressure is 150. But when you reach the lung, it's actually not 150 anymore. Yeah, because it's affected by temperature, humidity, and also the carbon dioxide. So when you reach alveolar level, it's already 110. It's no longer 150. Yeah. So then that diffuse down into the alveoli, that reduce some more, then become 90 to 100 concentration. Okay. So move on. This one, very difficult. Next. Next one. Yeah. Next. Okay, now so this is a very important graph. So when you look at the ventilator, there is a inspiratory tidal volume and expiratory tidal volume. Okay. So which one is more important? Inspiratory tidal volume or expiratory tidal volume are more important, or it is more reflective of what the patient's tidal volume.
Expiratory.
Expiratory. Why expiratory is more reflective?
There is it also depends on because we have persistent and then we have net phase. So whatever go in may not necessarily everything that the patient receives, and sometimes there's also leak happen. So expiratory volume is actually more reflective to whatever that the patient receives.
Yeah. So I mean, let's say if the tubing, there's no leak in the tubing. So yes, you're correct. Expiratory tidal volume is more reflective of actual tidal volume. So that is number one. Statement number one. So in the non-leak tubing, that is a tubing is not leak. Expiratory tidal volume will reflect the actual tidal volume that patient have received. The second is that because we are doing the forced inspiratory as compared to the negative pressure inspiration. So during inspiration, so that sometimes is because it's a positive pressure. So the positive pressure causes some distension of the ventilator tubing. Yeah. So the ventilator tubing distension sometimes can be calculated as part of the tidal volume. So that they will need to take into need to be very, very careful about this. Especially so when now most of the time the ventilator, they are compliant compensation. right? Compliant compensation means that the machine will automatically calculate out because when you distend, during inspiration, when you distend, so this plastic tubing will go to slightly inflated as well, right? So that will contribute to the increased tidal volume, right? Will contribute. So when the machine self-check the initial step, so the machine with a lot of time will calculate the compliant, right? So like for example, I'm using servo view. So at the last step of your calibration, the machine will ask you, do you want to compensate the compliant? Yeah, it's very important at this stage. Because why? If you didn't compensate the tubing compliant, yeah. So what will happen is that the machine will going to calculate the tidal volume, which include the tubing. Okay, so you might see that, okay, you set certain pressure, tidal volume of the patient very good, but then the patient just didn't ventilate well because the ventilate, although the machine show you the good tidal volume, but the patient just doesn't seem to be receive the appropriate tidal volume. So that's a problem, is that whereby the machine are actually calculating the distension of the tubing as well, which include into the calculation. You get what I mean? Yeah. So meaning that it's important for us to compensate the compliant, especially when you do the machine shelf check. Yeah. So more so if you want to do ventilation with volume control. If you use volume control type of ventilation, so you must always make sure that the tubing had to be constant, compensating the compliant. Yeah. Right. So
if let's say the compensation is not on, is it okay by just monitoring the trend?
Then the calculation will not be accurate. So you'll be misled by the number. Yeah, because your minute volume, tidal volume, that will be calculated as such. Yeah. So you might be falsely reassured that you have been already giving a good tidal volume. Yeah.
Okay, understand.
Yeah. So that is important. So the other thing is that when you say that yes, expiratory tidal volume is most accurate measurement of tidal volume, but the problem is that if the tubing is leaking, so if the tube is leaked, then it is no longer accurate because the air are escaped to the side, then you're not able to measure accurately. Okay, yeah, move on to the next one. Yeah. Next one. There's one, yeah, next one. Yeah. Okay, if there's one measuring about the, talk about the transmural pressure, right? You can go to the one that transmural pressure. I think the earlier. Okay. Transmural pressure. Yeah, okay, the transmural pressure. Okay, so in a spontaneous breathing, what do you think that the alveolar pressure will be during the inhalation? So in a patient with we all are spontaneous breathing. We inhale like that. So what do you think about what is the pressure at the alveolar level during inhalation? Lily?
Is it?
Sorry.
It should be same as it should equalize itself to the atmospheric pressure.
If you equalize itself, then the air will not go in.
The air go in is because the intrapleural pressure is lower.
Yeah, so the intrapleural pressure is lower. Yeah, okay. So so the intrapleural pressure during inhalation, what will be the pressure like?
Sorry.
So we inhale, when you inhale, right? So this is a concept we probably need to be have to be very careful and understand. So when you inhale, okay, yes, you're saying that because of the Boyle's law, the Boyle's law, telling you that then when you increase the tidal volume, when you increase the volume in the pleural space, so the pressure will drop. Because what we're doing, we increase the tidal volume, the volume of the pleural space, the pressure will drop. So the pleural pressure itself is between you during inhalation is -4 to -8. You get what I mean?
Sorry, I was thinking just now.
Hello.
And now I sign in using phone because Arsenal line also not good.
Okay, no worry. So you look at this diagram. You look at this diagram. The diagram show you that the pleural pressure. The pleural pressure during inhalation. So it might be a -4, -8 during inhalation. So that create because according to Boyle law, the pressure drop, then the air will come in. So what is the alveolar pressure at the time during the air come in? Yishan, you want to jawab?
Alveoli should be lower
pressure.
It should be negative and lower pressure so that the
Yeah.
air will come in.
Yeah, so it should be a negative. So how negative would that be the pressure is? Around -1. Yeah, around -1 centimeter water of pressure. So when you inhalation, actually our normal respiratory process, the inhalation process is a negative pressure. So it's a -1. So when you inhale, the alveolar pressure is -1 centimeter water. Then because of the pressure gradient difference that created by the pleural cooling, so then the air will come in, right? So on the opposite end, so when you exhale, so during the exhalation, so the pleural pressure, the external pressure will come in, So then the alveolar pressure become +1, +1 centimeter water. So that's why the air can go up, right? So you have to always remember your normal inhalation pressure in the alveolar level is fluctuating between -1 and +1, -1 and +1. So that create a pressure gradients and also the respiration. So now your alveolar is constantly receiving these two type of pressure, -1, +1. So imagine now if you ventilate a patient. When you ventilate a patient. So most of the time, what is the pressure that you put in a normal lung?
Are you referring to the PEP or what?
Just I mean, for example, patient post op come in. What is the pressure? 5, 5. Okay. What else are 5 and 5? Let's say maybe 10/5. Right?
10/5.
10/5. So you could imagine that 10/5. So 10/5 pressure is the pressure that you're exerting into the alveoli, which is normally only receiving plus or -1. So do you see the danger?
So meaning we will hyper inflate the lung, is it?
No. So meaning that we need to be very careful. The lung itself normally receive -1 and +1 pressure, right? So we are actually giving some time for us although we say that the pressure 10/5 is low ventilator setting, but this is the pressure that the lung did not receive regularly or normally. We're actually giving slightly higher than what the normal lung actually receiving. Our normal lung day-to-day spontaneous breathing is receiving plus and -1 centimeter pressure. So in a patient that we so-called low ventilator setting 10/5, he actually receiving 10 times more than what the lung usually receiving. Do you get what I mean? Okay, so it is a external additional pressure that you exert into the alveoli. Meaning that so whatever pressure that you put to the patient, we are always giving higher, right? So have to be always when the patient are ready to be extubated, please extubate so that you you reduce barotrauma as much as you can. And having said that, in another situation, if you sedate and paralyze this patient, right? Comparing a patient could have a possibility of spontaneous breathing, yeah, to another patient that heavily paralyzed, okay? Then it's a similar pressure, I give 10, 5, okay? Would that make any difference?
I think yes, because if sedate and paralyzed, the patient would not generate even more negative pressure, right? It's solely dependent on the positive pressure ventilation that we're giving.
Okay, so that means that's the importance of the so-called the transpleural pressure. Okay, meaning that so in the well awake patient, you ventilate the awake patient, you slightly sedate them. But when they're well awake, the body, the muscle are always in the situation that will always keep your lung open. So all the muscle will try to put your lung open and will maintain it to be open naturally. Yeah. So yeah. So as compared to a sedate and paralyzed patient, whereby you lost the capability to keep the lung open. Yeah. So your muscle, everything will relax, right? So then subsequently, your pressure they're going to exert to the same pressure, yeah, the amount of stretch to the alveoli is actually much lesser. That's indirectly telling you this so-called the transpulmonary pressure type of principle. Yeah. So when you have an external pressure or your patient will lose capability to maintain the alveoli to be open. Yeah. So this transpulmonary pressure actually will increase. Yeah. So then whatever pressure that you're going to exert, the pressure effect onto the alveoli is slightly lesser as compared to the other one. Okay, right, yeah, okay. So you move on to the functional the FRC, functional residual capacity. Next slide, yeah. Next slide. Next slide, yeah. Next slide. Next slide. Next slide. The one that you show functional residual capacity. The total lung capacity. Next. Yeah, this one. Okay. So how are you going to determine the patient is in FRC? So for example, in terms of X-ray wise, so how can you say that this patient you actually put the patient at the FRC? Yeah. You're talking about the normal patient, not the severe obese patient. Yeah, so
when during exhalation.
During exhalation. Okay. I mean, from the X-ray wise, how you're going to determine you're at the FRC? Yeah. So for example, when you have you ever wondered why when you put patient on high frequency, you always want to do X-ray daily?
Yes, because we wanted to see how's the lung expansion, whether your MAP is adequate or it's excessive, basically.
Yeah. So what actually besides looking at that, so what are you actually want to look for? So you mean that so if the lung expanded too much, then you need to reduce it, right? So if the lung is deflated, then you want to increase it. Okay. So you're trying to achieve something, right? Correct or not? So you're trying to achieve something. the something that you try to achieve is that the lung expanded to the rib about 8, around 8 to 9, correct?
Meaning calculate the rib, is it?
Yeah, definitely. So I mean, you're trying to, when you do an X-ray, every time when you do high frequency, you want to see whether the lung volume is well expanded, right? So by the definition, what is the definition of well expanded lung?
From the chest, is it?
Yeah.
So meaning that the ribs are
Yeah.
normally and the ribs are around 8 to 9 lah.
Yeah, correct. So I mean, you're trying to achieve the rate to 8 to 9. Yeah. So when it is hyperinflated, it is more than 8 to 9. So you have to come down, right? Okay. So when it's less than 8 to 9, then you say that it's not enough. You want to inflate some more. Okay. So what are you trying to achieve on the 8 to 9? We are always try to do 8 to 9. Why? Because that is what we call functional residual capacity in the X-ray point of view. Yeah. So that's very important. So we are actually the reason we want to do X-ray, we try to ensure the lung it is at the position of functional residual capacity, which from the X-ray point of view, you're going to see probably at the area around 8 ribs. So that is a nice nice area that you want to achieve. Yeah. But having said so, it will be out a little bit if a patient has severe obesity. So that is, you cannot use that as a good marker, because when you see when they're obese, their lung volume is much more relatively much more smaller. And so the reason why we get that highly wide X-ray for patient high frequency, we want to achieve the lung expanded up to 8, 9. The reason why you want to put that 8, 9, the reason is because we want to make sure the lung is at the functional residual capacity. Yeah. Why we want to make sure the lung is at the functional residual capacity?
So basically, we wanted to recruit all the
Lowest PVR.
Yeah. So the main thing is that you ensure that the lung is recruited. Yeah. And also importantly is that when the lung are expanded at the functional residual capacity, so the pulmonary vascular resistance is the lowest. Yeah. Remember the pulmonary vascular resistance graph over the lung volume? It's like a Nike shape. The Nike thunder Nike though. Yeah. So when the lung is at the functional residual capacity, the pulmonary vascular resistance is the lowest. Yeah. So then will improve the BQ, any possibility of BQ mismatch. So that is the important part why it is put it as such. Yeah. Okay, I think good. Thank you very much, Li. Yeah. Thank you for sharing this one. Yeah. I think there's some confusion later on just now in regards to the paralyzed and non-paralyzed. Maybe you go back and the pressure effect to the paralyzed and non-paralyzed. Yeah, you go back and read into what the topic on transpulmonary pressure. Yeah, so when you're able to understand what is transpulmonary pressure, then probably you can understand a bit more the thing that I explained to you just now. Okay, right. Any other question?
Dr. Cho, Myra here.
Myra,
I just want to re-clarify about this compensation thing.
Which one compensation?
So the compensation tubing though, the ventilator. Some ventilator has the option of tube compensation on, tube compensation off. So so meaning you should compensate for the tubing, am I right? Or no?
Yes, please compensate. Please compensate the compliant. Yeah. You have to compensate the compliant, then only you can have accurate tidal volume measurement. Yeah.
All right. Okay, thank you.
Okay.
Charles, another thing, just now you're saying the functional residual capacity, in a way, that's the best time, sorry, I just want to clarify, it's the best, I would say,
volume that you want to ventilate. they want to ventilate in high frequency.
For the best VQ optimal perfusion, right? Ventilation perfusion, and that is at the at the chest X-ray expansion of between 8 to 9 ribs. Is that so?
Yeah, correct. That's what we are for high frequency. That is what we are aiming for, and that is what we are trying to achieve. Yeah.
That's for high frequency. What about for normal other types of ventilation?
Normal quite difficult because you have constantly changing on inspiratory and expiratory. Yeah. So you're not sure what at which level that you're catching. So one thing good is high frequency is that the MAP is constant. So when the MAP is constant, you actually know where the diaphragm going to be seated. Yeah. And the variation is also very, very little because the pressure actually did not varies much in terms of the diaphragm movement as compared to the conventional ventilator that you're going to in out very dramatically.
Yeah. Does that apply to jet ventilator as well?
Yes. All high frequency ventilator. You know the principle of high frequency ventilator. First, definitely it's a high ventilator rate. Okay.
Yep.
Second, high ventilator rate supra physiology, but had to be as minimum of 160 or 180 breaths per minute. More than 160 or 180. So that's number one. Number two is that you must ensure that there's constant distending pressure. The distending pressure would be your PEP from the jet or MAP from the high frequency must achieve good equipment, which is mean sitting at functional residual capacity. So if you're not able to put the patient on the functional residual capacity, how high your jet or frequency that you put, you're not going to help. And so you have to recruit the lung with the MAP. So that's two important features that when you want to use high frequency.
Okay. Yep. Understand. Thank you.
Okay. Okay. I think it's 3 o'clock now. Yeah. Thank you very much. So next week, who is present?
Asliani.
Asliani, huh? Oh, okay. All right. Thanks so much. Okay.
Thank you.
See you. Bye.
Thank you.
See you.
Bye.
Bye.
Thank you.